Hey, um, good evening, people. Here, I'll turn my camera on. Hopefully, this is live and working. I'm not 100% sure. Heads up in chat if it is. Um, all right, yeah, I think I'm live. How's everybody doing this evening? I don't know how many of you have previously seen the stream I did last year on WPATH. Um, but we'll probably go through a little bit of that first. I'm gonna put up a stream, but essentially, feel free to ask questions. I'm totally open to this being more of a conversation than it being a presentation, especially considering there's only 4 people or 3 people watching, and one of them's me, I think. Um, so, but yeah. So look, the thing personally that I have here that my issue is how the WPATH has corrupted medicine and how they kind of approach children. In a lot of ways, the way in which they have written their um, standards of care is to allow doctors to kind of do anything for what they perceive as patients that need gender care and be protected from liability and insurance. And I think that in a lot of ways, it exists to justify the people that are now involved in WPATH, um, their own transgenderness or gender nonconformity. So, real briefly, we'll just talk a little bit about the history. WPATH is the World Professional Association of Transgender Health Care. Um, they put out what are called standards of care for how you should treat transgender people. The actual organization started in the 50s with a different name, the Harry and uh, um, Harry Benjamin. Can't remember the whole acronym, but look it up. But anyways, so the first like inklings of gender transition stuff and whatnot started in the early 1900s, actually in Germany, and the first supposed like successful gender transition surgery was in the 1930s, but a lot of those records are lost because of Nazi Germany. It really came to prominence in the US, and I'm going to turn myself off and go to the screen to put on like some camera and stuff or some video and stuff um, throughout the what we do. Let's do the right one. All right. So this is Christine Jorgensen. She was a American GI that transitioned to being a female and was the first really like popular out there story of gender transition in the United States. There was a New York Times headline December 1st, 1952. XGI becomes blonde beauty, talking about how Jorgensen had traveled to Denmark and had gender surgery. So, like I was saying, Jorgensen came back to the U.S. and ended up getting most of their care from Harry Benjamin, who was a German endocrinologist who had proposed a fake tuberculosis vaccine that when he first came to the U.S. before he got into gender surgery and treatment and whatnot. But there was another famous transgender person named Reed Erickson, who um, who was born into a family with a lot of money and ended up funding a lot of this early gender transition research and care in the 1950s. So the original like idea that ended up becoming the ultimately became WPATH was the Erickson Educational Foundation, which sponsored the first 3 symposiums, international symposiums on gender identity, and the precursor to the WPATH. This ended up funding also the Johns Hopkins Gender Clinic, which people probably know who John Money is and his experiments. But he was famous for his experiments on those twin boys with the botched circumcision, the Reimers, who they tried to transition after the botched circumcision and raise them as one is a girl and the other is a boy, and they both end up getting into drugs and killing themselves. It's a sad story. But so, like, in a lot of ways, the early days of this is fraught with controversy. And my intention, one of the things I've been reading to is the history of this. My intention is to talk about it. Because in my mind, what happened is from the 50s to the 70s and 80s, this organization was focused on educating and researching and trying to find better ways to treat people with what they recognized as a mental health issue of not being in tune or connected to your own body with your mind, gender identity disorder, whatever you want to call it. At some point in the 80s, into the 90s, and now in the 2000s, the organization became taken over, controlled, but the people in the driving force of the organization were people that were either trans themselves or were propagandistically driven towards being an activist for trans, needs. There's this website that was put together called Transgender Map that was put together by a trans activist that raised a bunch of money to supposedly put something about trans stuff. And really what it is this, it's hard to go through, but again, something I intend to go through at some point with people and look at all this different stuff. But essentially, it's these diatribes about people that this quote unquote trans community has problems with and has had issues with. People like Michael Bailey, who is a big force behind the autogynephilia, if you've heard of that idea, and they don't like that because it upsets them. So anyways, in the 90s, the WPATH was taken over by people who were trans themselves or activists. And the reality is to be part of the WPATH, all you have to do is pay a fee and work in one of these, fields. It's not like you have to be an expert. It's not like you have to be anybody special. So you can really see how this change happened in the difference between the standards of care number 6 that was put out, and then the standards of care number 7 and 8. Or I could be off. It could be like 5 and to 6. I don't. I'll have to double check the numbers, but essentially what happened is one of the early people in the organization, Richard Green. Or do I have his name wrong? Richard Green. How many Richard Greens? I thought that was his name. I got the Green Benjamin International Gender something. I can't remember what the D stands for. All right, yeah. So this guy, Richard Green. He is another one of these guys, but he was the oh man, there's too many. But he was the one of the presidents of WPATH. He ended up leaving because he got into a fight with them about how you approach this stuff, because he was more of a scientific approach as opposed to an activist approach. And like I say, this is a transgender map site, and it's all these like long diatribes about their hate and anger and issues with these different people. And again, I wanted to talk about autogynephilia and those kinds of things at some point, but not tonight in any depth. So he ended up actually leaving the WPATH. He was the president because he was not happy with them like removing a lot of the stopgaps that required people to get mental health care along with transition, and that treated transition as mental health. Um, in the most recent version of the WPATH's standards of care, they've gotten rid of like an ethics chapter that was in there. They removed age requirements for things. I mean, essentially, in a lot of ways, like I was saying when I first started, they seem to very much exist to protect doctors and allow them to do whatever is they feel is necessary to treat their patients, while at the same time, their care model argues that everything is essentially solved by gender transition. So we'll go to my PowerPoint thing that we had here from before, and we'll go through it. And my intention is to kind of run through this a little quicker than I did last time I did this, just to give a little basics in case there are people that haven't seen stuff. And then we'll go through the leaks. What the leaks are is two things. One, they are a 45-minute or so compilation of clips from a WPATH education seminar that was going on prior to the release of the WPATH Standards of Care 8 in the end of 2022. The other things that were leaked were emails and messages from the WPATH forums. Behind the scenes, people, providers, and many of them part of the WPATH like team, discussing how they don't really have true understandings of what they're doing, and much of what they're doing is experimentation. The biggest issues are in things that I had talked about before, and we'll go over again with the leaks, I guess, as we go through it, where there's a lot of concern in how the WPATH allows people to consent, and how they see consent as very arbitrary, maybe not arbitrary is the right word, but very unnecessary, and not as rigorous as one would want with such permanent changes. So just to briefly touch, we can make this full screen. So numbers are going up. More and more people are identifying as transgender or gender nonconforming by both generation and by overall population. My point that I wanted to make here and that I made before in showing this slide was that there's a very rapid increase in the rate of identification in the younger generations as compared to older generations. Now, one of the things that exists along with this is, this argument is generally from the WPATH people and from the activists, is that the only reason these numbers are so precipitously rising, out of proportion in the younger generations is because, everybody that's older had to bottle all this stuff up and couldn't express it because of society. But now society is more accepting, so we can. So I was, here's more numbers. We can go through them at some point. It's not really that important right now. If somebody wants to see this graphic, I can share it with them. But essentially, it's just talking about how the numbers are going up like crazy. There's a lot of comorbid mental health conditions. Suicide is a high risk, or at least associated. There's a lot of data that was just released in the past few weeks, even showing that suicide rates with respect to transgenderism in and of itself are not actually any higher than the rest of the population. It's those comorbid mental health conditions that are the problem. One of the things that I was talking about just a minute ago was autogynephilia. I guess I'll touch briefly. There are a few different reasons that are posited as to why people are trans. Autogynephilia is one. In a sense, it's the idea that male to female, men that become women, have a fetish for being female, like a sexual fetish is tied to sex. There's this newer theory called rapid onset gender dysphoria, which is what I want to touch on, where we're seeing young girls, generally at early puberty, often associated with autism, um, showing up with gender dysphoria and being pushed down this pathway. Um, so let's see. Uh, I guess we'll just kind of run through this real quick. But this is Rachel Levine. She's the Assistant Secretary of Health and Human Services. This was at a summer Pride event, and she's basically talking about. My point here was how even up to the government levels, we're relying on the WPATH. And that wording is straight lifted from the WPATH. You know, that's one of their biggest things is talking nonstop about how transgendered healthcare is suicide prevention. They essentially argue throughout their entire 350 page or so standards of care that the even though there's weak evidence for all of the things that they argue, the oh, you couldn't hear the video. Oh man. Sorry. Let me unpresent and represent and see if that does it. Tell me if you can hear this now.
We often say that gender affirming care is healthcare, gender affirming care is mental health care, and gender affirming care is literally suicide prevention care. Would that be?
You guys able to hear that? Good. So yeah, so I must have not turned on the audio sharing before. That was my bad. But yeah, so the uh that's basically their stance on everything. As we'll talk about, they basically show that there's weak evidence for everything that they talk about. And the reason that we should push forward anyways is because somebody's going to kill themselves, and that's been shown to be not the case. The rates of suicide after surgery don't really drop, and it's all self-fulfilling prophecies for WPATH because they argue that's because of minority stress and the lack of communal support and things like that, and the general society is what drives people to suicide, not the underlying issues that may exist. Briefly, I had talked about how there's a lot of money coming in from this, and I think that might be part of what's driving it. The diagnoses are going up, the treatment is going up. If people get the diagnosis, they get the treatment. It's consistently where things are going. The majority of and the takeaway I had from those slides, but essentially is that the takeaway is that the majority of the adolescents that are getting gender affirming surgeries, specifically chest surgeries, mastectomies, are upper middle class white girls in liberal cities. They're 98.6% female, 77.9% white, 60% are on private insurance. Half of them, their family make over $80,000 a year, and like 70% live in areas with 1 million or more residents. That's what we've seen is basically a lot of this gender dysphoria stuff is in big blue cities, upper middle class, big blue cities. This is play it real quick, but this is a doctor or an insurance like administration person at a hospital that does gender stuff at Vanderbilt, talking about how much money it can make them.
Starting in January 1st of 2017, according to the Affordable Care Act, insurance carriers are mandated to cover medical expenses for trans folks. Some of our VUMC financial folks in October of 2016, starting a couple of years ago, put down some costs of how much money we think each patient would bring in. And this is only including top surgery. This isn't including any bottom surgery. And it's a lot of money. These surgeries make a lot of money. So female to male chest reconstruction can bring in $40,000. A patient just on routine hormone treatment, who I'm only seeing a few times a year, can bring in several $1,000s. So that requires a lot of visits and labs. It actually makes money for the hospital. Now, these I got from the internet, but it's from the Philadelphia Center for Transgender Surgery, which does a lot of surgery for patients. And I just want to give you an idea of how much these bottom surgeries are making. And I think this has to be an underestimate. This is for a vaginoplasty. They're quoting roughly around $20,000 for a vaginoplasty, but that doesn't include your hospital stay. That doesn't include your post-op visits. That doesn't include your anesthesia, your OR. So I would think that this has to be a gross underestimate. I think that's just like the surgeon.
Not to mention that like 70% of phalloplasties creating a new penis end up having revision surgeries and complications. And I think it's like 60 or 50 some odd percent of people that get vaginoplasties, the vagina surgery, the neovaginas end up needing revision surgery. Anybody that's been visiting my gender clinic on the Unstable Kids Discord, and if anybody's not there and would like to see it, they're welcome to, we can send invites. Oh, Baxter, you're all wet, dude. Don't want wet pants. Sorry. Although you probably are entertained by that. But yeah, so the complication rates are high, and the secondary surgery rates are high, the revision rates are high. And as you guys have been seeing from the like Reddit stuff I've been posting that I see in the Twitter stuff, a lot of people are openly talking, and I don't usually post the graphic images that people are posting of their neo whatevers, but they're not. Yeah, they look like they've been butchered, a lot of them, the vast majority of them. So it's not even just what she's quoting for the 20 grand for this surgery and the 30 grand for that. That's minimal in the whole scheme of things, because these people need tons and tons of aftercare, and they're tied to the healthcare market for the rest of their lives. They're medicalized patients that pay.
Piece of it, which anybody who's ever been in the hospital knows that that's like 10% of it. And in the female to male bottom surgeries, these are huge money makers. Again, I think this has to be an underestimate that they're quoting around $20,000 for a phalloplasty. There's been different things that I've read that said it could be up to $100,000. Dr. Winokur, who's our surgeon, says that there's entire clinics where the entire clinic is supported just by their phalloplasties. And that is like a fraction of the surgeries that they're doing. These surgeries are labor intensive. They require a lot of follow-ups. They require a lot of OR time. They make money. They make money for the hospital. Starting in
No, it didn't freeze. I muted myself when Baxter was climbing all over me, and I was giving him a hard time. My bad. Sorry. I'll get better at this. Anyways, let me go back. So what I was just saying briefly that you couldn't hear is the Tavistock Clinic, which is the one in the top left here. It's the UK one, because of all the stuff we are going to talk about, with WPATH and that type of affirmative care model. That's what the Tavistock Clinic was shut down in 2019, or not 2019, last year, 2022, 2021, maybe 2022, 2023. But yeah, they were just shut down. The other thing about these increasing numbers of stuff, there's increasing rates of people being non-binary, which is the top right, the Canadian one. But there's some data, and I mentioned in Discord and things like that before, how women specifically on college campuses are more and more in the US are more and more identifying as bisexual, but they're only actually having heterosexual sex, which, lends some credence to the idea that maybe some of this is people, trending as opposed to, having real things going on. This is a story out of the UK about a gender doctor who was giving kids hormones after Skype phone calls, like a 10-minute Skype phone call. Prescribed puberty blockers to a 9-year-old that was transgender after a 10-minute Skype call. Yeah. No exam, no nothing. So I don't know how much you guys actually know about puberty blockers and whatnot. We'll just talk real briefly. I'm going to skip this video. This is just talking about where the medications that are used for puberty blockers are prescribed for precocious puberty. They are what are called GnRH analogs, which basically stop you from going through puberty. For puberty, you start puberty at basically between 8 and 13 for girls and 9 and 14 for boys. So you're talking about putting kids on these meds between 8 and 9 years old, potentially, at what's called Tanner stage 2. Some stuff about medications. We can go through that if people want to. Essentially, the bottom line with the medication stuff is that the WPATH and all of these clinics say there's no problems with them, but the reality is what these medications are used for, other than this hormone blockade, is they're used for treating men that have paraphilias, pedophilia, things like that, to stop them from having a sex drive and to chemically castrate them. And then the other thing that we use it for is for end-stage prostate cancer, because it decreases the size of tumors, but you only use it for end-stage because it has long-term side effects. And then for maximum 2 years in the setting of precocious puberty, early puberty, to delay it a little bit, or for ovarian and some other female or reproductive cancers that again, used for very short term, 6 months to a year, for pain and things like that, to decrease tumor size while you're treating. On the contra side, what these end up doing is they decrease your development, muscle, brain, organ, development. So these kids that are on these things for long periods of time, it impacts them in that way. They put you at risk for cancers. Even the cross-sex hormones put you at risk for cancers. Nobody talks about it, but like the testosterone that these female to male trans people take put them at high risk for liver cancers. But so this is all based off of what's called the Dutch Protocol, which was designed based on a cohort of people that were very heavily selected for, that did not have any mental health issues, that had supportive families, lived in supportive communities, people that would be successful with these types of treatments. They put them on puberty blockers at 12, and they had to have a diagnosis of gender identity disorder, which used to have more criteria than it currently does. Then at 16, they would start them on cross-sex hormones. And then 18, if the person wanted, they would do surgery and, whatever hormones you need to stay on afterwards down. And they claimed success, but in the long-term follow-up, it's question about these people actually thriving is low. It's about half of them don't seem to be doing great. So, look, how do people pay for this stuff? Insurances pay for it. State insurances are paying for it. Organizations pay for it because it's full of activists now. In the places with like national health and things like that, they've agreed to pay for it. I see people crowdfunding for surgeries. But one of the concerns that we see in the WPATH leaks is that like they're talking about doing these surgeries that require a decent amount of aftercare and long-term aftercare on homeless people for fuck's sake. Like it's ridiculous. This is talking about the Dutch protocol, and like I say, how it is very specific and how it's kind of misdescribed in the WPATH. This is where I was just kind of trying to show how medical guidelines differ from the way the WPATH has written their guideline, and how evidence and the weight of evidence is very important, but the WPATH makes strong recommendations based on poor and weak evidence. So this is from Planned Parenthood out in California. Now, this is not for minors, but if you're 17 and over, you can, within one visit, be prescribed hormones. On the right, you see stuff from Kaiser Permanente. This is specifically a training that they were doing in Southern California on gender affirming care and talking about how, you can get approved for these things with one letter for a mastectomy. If you're under 18 years old with parental consent, you can get it. There's no lower age limit for these things. If you want a vaginoplasty, you need one letter from, clearance. You have to be on hormones for 6 months. Your estrogen levels have to be at a certain number. Your BMI has to be below 40, but that's the case for any real surgery, unless it's an emergency surgery. And then if you're under 18 years old and you've been on treatment for 12 months and you have parental consent, they don't put minor, lower age limits on that. And that's based on the WPATH's, recommendations and care stuff. There's so much like intentional ambiguity in the language of the WPATH that people can say they're following the guidelines while really skating the line to what they want to either do or not do. Yeah. I mean, look, covering trans stuff, surgeries and things as compared to like insulin or weight loss surgeries even. I'm with you on that one. This is a clip of Dan Crenshaw. He's questioning a Yale assistant professor. Her name is Meredith McNamara. This is from a House Energy and Commerce meeting about parents' access to care.
When you're talking about permanent physiological changes, do you not agree that you might want extremely strong evidence of the benefits? And there is no systematic review that states that there is strong evidence of benefits.
Sir, are you aware of how the quality evidence grading system works and how it's applied?
Yeah, we read through it. That's why I'm citing these journals. The British Journal of Medicine looked at 61 systematic reviews with the conclusion that, quote, there is great uncertainty about the effects of puberty blockers, cross-sex hormones, and surgeries in young people. Journal of Endocrine Society came up with the same conclusion. Even the American Academy of Pediatrics, they all cite the lack of evidence. Tell me a journal that has done systematic reviews that cites different evidence, that cites strong evidence for benefits of these therapies.
The standards of care were developed based on extensive.
You're not telling me any journal. You're not telling me any study. Don't say standards of care.
Yeah. So
Tell me one.
The standards of care.
That's the standards of care. That's not a journal. That's not a study. That's not an organization. That's not an institution. You're just saying words.
And one of the things I'll add to what they were saying that's really disheartening to me is the WPATH goes, well, especially since these leaks came out, the American Pediatric Association, the American Medical Association, the American Psychiatric Association, let's just keep going down the list. they all agree with our care model. So you should believe them. And when you look at these people, they go, well, it's not us saying it, it's the WPATH saying it. So you should listen to us because of them. So it's this circular logic of, well, we're the experts, so, believe us because the other experts believe us. And the other experts go, well, we're not the experts, but believe us because the other experts, it's this ridiculous circular reasoning. And yeah, I agree with what Brent said. Here's more of Rachel Levine real quick. The Assistant Secretary of Health and Human Services. She is trans herself. Obviously, I think people know that. And this is from June of 2023. It's a webinar for students. I don't remember what age students it said, but it's for the Department of Education on inclusivity for students of gender.
As Assistant Secretary for Health, I am urging us to base medical care on facts. Gender-affirming care is medical care. Gender-affirming care is mental health care. Gender-affirming care is literally suicide prevention care.
I can find you where it says those exact words, the line she just dropped from the WPATH itself.
It is based upon decades of study. It is a well-established medical practice with a strong evidence base and standard of care through WPATH, the World Professional Association of Transgender Health, with an update that was...
And so this is what I'm talking about, where you actually look at the WPATH guidelines and it's weak evidence, but they say it's strong recommendations. So technically, she is not lying when she says, we, have this resource that says there's strong reasons to do, or there's strong, or gives strong recommendations to do whatever.
That was published in September of 2022. Based upon decades of research and medical evidence and analysis, and many respected medical organizations from many diverse fields agree that gender-affirming care is medically necessary, safe, and effective for transgender and non-binary youth, adolescents, and adults.
Yeah, so I brought up Crazy Bee's comment because, that's something that I've been talking about and thinking about is the WPATH sees the Hippocratic Oath, the part of do no harm, as do anything in your power to do what this patient wants, as far as, a la carte medicine, essentially, because the Hippocratic Oath says do no harm, so they're going to hurt themselves if we don't help them. The way I understand the Hippocratic Oath is you should do everything you can to heal a person and help a person, but you shouldn't be harming a person to help them. And they don't see what they're doing as harm because they're so focused on this idea that suicide prevention.
As Assistant Secretary for Health,
how do I? Yeah, go to the next slide. All right. This was just some articles. All right. Let's see. I think this is just a few minutes long. This is from a Texas Senate committee hearing, and they're questioning a psychologist who's a member of WPATH at a hearing specifically about WPATH. This is from March of 2023. And I'll pause along the way to point out a few things. The first thing that they talk about is the affirmative care model, which is what the WPATH is built its entire recommendations on. And they've also built themselves on this idea that gender care is healthcare. So, you don't need psychiatric care. It's not mental health issues. It's natural. It's good. It's normal. They've normalized it. So, therefore, it's irrelevant to have any psychiatric care to obtaining, gender treatment.
Senator Campbell.
Thank you, Mr. Chairman.
She's a firecracker.
Whenever a child comes in and says, I'm a trans kid, do you believe them?
Yes.
So when a 12...
And that's what I'm talking about when I'm saying that, it's a la carte medicine. They're not talking to the patient and going, let's figure out where this is coming from. Is it real? Why is it going on? Did you have trauma? Do you have, other underlying mental health issues? They're just going, you're trans? Okay, sounds good. You want your penis cut off? Great. You want to keep your penis and have a vagina made and 2 genitals? Great. You want to have no genitals and be a Barbie doll? Great. Like, whatever you want, we'll do, because we don't want you to hurt yourself.
12-year-old comes in to a clinic and says, I'm trans, you believe her, if it was a
Yes.
girl. So what's the basis for prescribing puberty blockers? Is being trans enough, or are there some trans kids that you might say no to?
I'm not a prescribing physician, so I can't speak to the.
Yes, but you are the one that is there to either sign a paper that says they've had therapy and it's okay to put them on medications, right?
I am there to say that they meet criteria for clinical distress.
So
which
they
may be-
see you, they get to you because you're a known expert. So they're referred to you.
So this is something else that is interesting. What tends to happen is people go see their primary care provider. This might get brought up about the transgender stuff or the gender issues, or maybe the parents bring it up. The parent or the provider goes on the internet and looks up a gender clinician, and their assumption when you send somebody to someone who's advertising or listed as the expert psychologist in the area on gender care, that they're going to actually be analyzing the patient. They're going to be reviewing things. They're going to be really no. These people just perform affirmative care. They're in the business of finding a way to get you your surgery. They talk in some of the leaks, and probably find it, or I can show them at some point if we don't get to that stuff tonight. But where they're talking about how they use different reasons than the actual medical reason to get somebody surgery, because they don't want somebody's insurance not to pay for it, or they're worried about somebody's insurance not to pay for it, so they put it down a different reason, and they're essentially committing medical fraud.
You see them, you
They meet criteria for clinical distress.
believe them, you sign a form, they take it to the doc, and they're able to they've had the counseling, and they're able now to get the medicines.
It is not that simplistic, no, Senator.
Well, I'm just cutting to the chase. That's what they do. Do you ever tell them no? Do you ever not sign one? If they say they're trans child,
There's
do you
not,
ever not sign the form that would allow them to get therapy from a physician?
there's not a form to sign.
Well, you sign something, a letter.
I write an individualized letter.
Okay,
when
is
that
there-
something that a parent requests that I provide for a treating physician?
Okay,
in
so
concert-
let me stop you there. I just don't, it's a letter, not a form. Is there ever a time when a trans child comes in, or a child comes in, says they're trans, you believe them, that you do not sign a letter? Because the parents are wanting a letter so that they can get the child on medication.
When, again, after
It's just yes or no.
conversation with the child and their parent about their treatment goals jointly as a family. And if I judge that, in what I know from psychological science, that's in the best
Okay,
medical
I
interest.
really don't need all that. But your decision is based on the child believing the child is a transgender child.
Yes.
So she spends all that time being evasive, only to finally answer, yeah, she just takes the child's word for
Or
it.
tell them,
Let me find where we're up to. I mean, it's just we were here-ish. But yeah, she spends a minute and a half being evasive, and finally, answers that she just accepts the child's belief as a diagnosis.
your decision is based on the child believing the child is a transgender child.
Yes.
Okay. So you used WPATH. You want to tell them what WPATH is? And do you use the recommended guidelines from this place called WPATH?
I'm sorry. Can you say that last part again?
Do you use the guidelines recommended by WPATH? And tell the group what WPATH is, please.
It's the World Professional Association of Transgender Healthcare. We are on.
And speak into that mic a little better.
It is the World Professional Association of Transgender Healthcare. We are on the Standards of Care version 8. And yes, I would say that I follow those standards of care in terms of what psychological care entails.
Okay.
She's very proud of it.
And members, this is, I call it, I do believe it's an activist group that is presenting itself like a medical group, and I know it's mixed
I agree
with different
wholeheartedly.
professionals, and they provide guidelines, but I have not seen, I'd like for you to share with us the research that you say you read your magazines, your journals all the time. I'd like to see research, true research, not just what somebody thinks, not what they've just seen in their practice, not anecdotal. I'd like to see research, because the European countries have all, Sweden, Dutch, UK, Finland, all, and I'm leaving somebody out, have all not found enough medical evidence, psychological evidence to support therapy with transgen therapy. They've not found that. They have found do you believe there's comorbidities? I think you did say they come in with additional DSM-5 diagnoses, correct?
Yes, ma'am.
So if they come in with those, are you directing care for if they're depression with an anxious mood or an eating disorder?
Yeah, Kate. There is a significant amount of comorbid mental health conditions. It's about 68%. If I remember correctly, I have the numbers in this presentation somewhere, I think later on. And there's a very high association with autism and autism spectrum disorders as well. It's a serious concern, and we see that in the leaks that came out this week, that they're talking internally about things like patients with dissociative identity disorder, multiple personality disorder, and like how do you have to consent all of the alters to be able to do surgery on these people and care? It's
Order. Are you taking care of that before you recommend gender affirming care?
If that is the predominant clinical concern.
But of course, if the child.
So that's following WPATH's recommendations. WPATH says if you have a mental health issue and it does not interfere with your ability to consent for gender affirming care, then there's no reason to be, deeply concerned about it and to gender affirming care to, get psychiatric or psychological care first.
Child says, and I am kind of locking you up in a box, because you're telling me every time a child says, yes, I'm transgender, that's a pathway they go down. But we know there are comorbidities related. Just gender dysphoria just doesn't come up isolated on its own. Well, let me do say, this World Professional Association for Transgender Health, their latest guideline, they deleted the chapter on ethics. They deleted all reference to age.
So this is correct. They completely deleted the chapter that was written on ethics in the WPATH Standards of Care 8. And I do have a slide where I'll show you, but they deleted age stuff too.
Recommendations. And they did add, you recall what at least one of the new viable gender labels are that they added to the book?
I'm not sure to what you're referencing.
They added a new gender viable or viable gender, a new diagnosis that a child can know they are. They added a new one. Do you know what it is?
Are you referencing gender incongruence?
No, I'm referencing eunuch.
Oh,
You aware?
no, Senator.
Yes. What do you think about that?
Yeah, they
Would
added
you like
a
to
chapter
tell
on
them
eunuchs.
what that means?
Eunuchs and
I'm not sure how WPATH has defined that term, and that
they had a chapter on eunuchs, and they also discuss people that, like I say, want no gender, people that want multiple genitalia. It's all fucking weird.
sounds like a medical term that would be outside of my scope to provide.
All right, well, It's exactly what it says it is, that a child can know that a male, they can know that they're a eunuch and they want their penis chopped off. And that they're old enough,
Well, here, wait, I'll let her finish. Sorry, I don't mean to.
penis chopped off. And that they're old enough at age 8 or so, they know that. So this WPATH, that you follow their guidelines, and their guidelines are not standards based on science, but they have added that diagnosis. So at some point, I'm expecting to see it in the DSM-5. I'll let.
So, Leah, look, we don't let kids get tattoos. I remember, and I don't have the story pulled up, but I have to pull it up because I bring it up so often. But there was a case that I remember reading about a few years ago where a kid in the New York area wanted to get a tattoo because his mom was getting a tattoo of his dead brother, and the tattoo person had the mom, sign a permission and then did it. And the kid was like 12 or something, and the tattoo artist got charged by the state for putting a tattoo on this kid, even though the kid and the mom were okay with it. So we don't let kids make those decisions, but we let them make these decisions. Yeah, we touched on it briefly before, Kimba, but at some point we can turn this into more of a series, and at some point we can talk about it in a lot more depth if people want, and spend an hour or two talking about it. But the actual chemical castration, the puberty blockers, the hormones, how all that works, I'm down for all of it. But yeah, I'm just kind of doing a more of a quick overview so that we can get a foundation, and then, in the coming period of time, go from there. Because I've been reading through the history. Like, what can I say? I'm a nerd, but I got a hold of this book that's like the first book that was ever published with a collection of, the research, the up-to-date research by, and it's put together by Harry Benjamin and John Money and, all those guys. And been reading it like it's, a novel or whatever. Just seeing how they thought about things. And like I say, it's fascinating how like their perspective on this stuff is much closer to mine than it is to the current WPATH.
That's if I looked at DSM-5 more. The American Insurance Company.
Can I tell a story real quick? So she mentioned the DSM-5. So my grandfather, may he rest in peace. I remember having a conversation with him a long time ago. He was a psychiatrist, and he talked about how he hated the DSM-4. And I asked him one day why, and he goes, because they made homosexuality not a psychological issue anymore. And those gay people, they're crazy motherfuckers. I mean, I was like, yeah, each your own. I mean, me personally, I don't, feel that way. But I do think in a lot of ways the DSM has is been influenced politically for sure. Yeah, they were doing them, back in the 30s. I don't know, they weren't so successful, but what's his face? Magnus Hirschfeld was his name, I think, was the doctor. And at least the claim is that this lady Dora Richter, I think likely it probably happened, but they probably all died horribly very quickly. I mean, I don't think that them being successful back then was getting it right. I don't think there is any getting it right, unfortunately. I mean, get close, but right, nah.
Look at this group.
So she's going to talk about how insurances
rely on what
rely
they
on
feel is
WPATH.
necessary, medically necessary. Do you know who Dr. Rita Catalia is?
No, Senator.
And that's really probably a loaded question, I'll admit that, because that's a chief psychiatrist at University of Pediatric Gender Clinics in Finland. So who's going to know about that? Except somebody who is an expert in their field reading journals. She's a top expert on pediatric gender medicine. She said, quoted, I'm quoting, "It is not justified to tell parents of young people identifying as transgender that a young person is at risk for suicide without medical treatments, and that the danger can be alleviated with gender reassignment." She added, The transition or suicide narrative is purposeful disinformation. Spreading it is irresponsible. So the association you used to get guidelines from is called the WPATH. It's called WPATH, World Professional Association for Transgender Health. So they are aware of all the data from these countries, which again is just data. I won't go any further, but members.
Yeah, there's a group called Gays Against Groomers that's spoken out a bunch about this stuff. But yeah, unfortunately, I don't think it's good for the LGB community to be lumped in with the T, because, like I said in the comments there, sexuality and who you're attracted to, I think, while gender identity is tied to that, I don't think the, wants and needs of trans people coincides with those of lesbian, gay, and bisexual people per se. This was about the eunuch stuff. So one of the guys who was connected to the WPATH, who was one of the authors, had his medical license revoked because he was involved in some pedophilic stuff, and he was giving patients puberty blockers and hormones without having a gender dysphoria diagnosis because he was following WPATH. And in Norway, you had to have psychological assessment and the diagnosis of gender dysphoria. But the other thing about him is he was part of writing the eunuch chapter. And the eunuch chapter in WPATH links to a website full of sadomasochistic and pedophilic fiction talking about raping and turning kids into eunuchs for sex purposes. Yeah, creepy. And it's in the freaking WPATH. And then, more on the eunuch thing. This is a lady who shows up in the leaks. Her name is Dr. Sidib Gallagher. I don't know. Kate might know how to pronounce this name. I'll post it. She's a Australian. I don't know. You down under people. You're weird. Right? You're over there. But yeah, anyway, so she's a trans surgeon, and she goes on TikTok as, I think she's the one that's Dr. Titus Deletus or whatever. But this is her talking about how they add the eunuch section and they do orchiectomy.
So is it possible for folks who do not identify as transgender or non-binary to get an orchiectomy? So in this video, I want to talk about a group of individuals known as eunuchs. And so eunuchs, broadly speaking, are folks who are assigned male at birth but may not be comfortable with the sexual characteristics. And in these patients, the medical community is beginning to understand that they can also benefit from gender affirmation surgery and healthcare. And so in some cases, this may mean orchiectomy or removal of the testicles. This group of individuals had an entire chapter devoted to them in the most recent guidelines, the WPATH, the World Professional Association of Transgender Health Standards of Care Guidelines. It's a group we don't know much about, but we need to improve on taking care of. So traditionally, the concern in the medical community was that if we do remove the testicles and therefore there are only very small amounts of sex hormones circulating, what sort of health problems would this cause? And we know from certain studies which are done in orchiectomy patients, or where we remove the testicles for folks who had prostate cancer, it's a treatment for prostate cancer, that they had osteoporosis or bones that weren't dense, or sometimes cardiovascular problems, sometimes mood problems, loss of libido, that sort of thing. However, it is possible to substitute with small doses of estradiol or testosterone itself, and it just depends really on the needs of the patient. This is a group that have been really neglected by the medical community. It's a very interesting group. We need more studies, but we are beginning to recognize that some folks do need orchiectomies who do not necessarily identify as transgender or non-binary.
So in that chapter on eunuchs, which is creepy as all hell, anyways, it talks about how children can identify as eunuchs. You've never had a reason to use your, and specifically, obviously, about males. Only males can be eunuchs, but you've never had a chance to even use it, even think about using it, or consider how to use it, and they're ready to take it off. But yeah, I mean, I don't know how long before some president, warlord, oligarch decides they need an army of eunuchs and bases the WPATH on the decision making for why it's okay. This is a Belgian doctor who is the head of the Belgian Center for Evidence-Based Medicine, who wrote a long article talking about how essentially the WPATH is experimenting on children, and that their recommendations for puberty blockers aren't evidence-based. He said, quote, if we had to review the WPATH guidelines at the Belgian Center for Evidence-Based Medicine, we would actually have tossed them in the bin. And like I say, it seems that from the leaks, it's likely a lot of these people kind of knew in their heart of hearts that they were kind of experimenting on people. I just showed this to talk about, briefly how there's this other set of guidelines for the actual medications, and at least it's a guideline how medical recommendations are usually presented in papers, where you have quality of evidence, and they tell you what they're, how they do it, how they qualify, what they recommend, what they don't. They try to be short, concise, to the point. The Endocrine Society guidelines is 35 pages. The WPATH is like 260 plus another like 100 for some other crap. They have grading and evidence in the guidelines normally. The WPATH doesn't do that. And a big part of what the WPATH does is on policing language, but not on defining terms. So they talk about how language needs to be unclear and expansive and inclusive, not about defining what you actually mean, where the Endocrine Society does. And again, if people really want to go through both papers, we can go through them in depth. But yeah, this is just talking about how grading works. But essentially, in medicine generally, you don't make strong recommendations based on weak evidence, which is what the WPATH does. This is from the Endocrine Society, how like every recommendation they have, they give a weighted strength to based on, the evidence. And you can see most of it is low quality evidence. Whereas then you go look at the WPATH. This is from WPATH. And they're just like throwing this stuff in with no recommendations whatsoever on how strong or whatever. And then, you have like real follow-up protocols from Endocrine Society, not just this giant blocks of text. You have hormone levels with actual numbers, dosage amounts. Like, that's how it should be. And then, they're basically quoting each other. So this is a table from the Endocrine Society on the left, talking about what makes people eligible for treatment. And they just reproduced it from the WPATH. And then you go to the WPATH, and they talk about how they base their hormone recommendations on the Endocrine Society. So everybody is just citing each other in circular motions. This is WPATH itself. So like I say, they're very focused on terminology. They have a whole chapter talking about how like, to talk about things. Then they go start talking about adolescence and what their actual recommendations are for treating adolescence. The one thing I'll point out for our purposes is they talk about that an adolescent has reached Tanner stage 2, is ready for puberty suppression. That's really disturbing because, we know that somebody at Tanner stage 2 hasn't had enough sexual development to even like have a real orgasm. So we're cutting off people's ability to, have sexual maturity before they even know what that means. They say you should be informing the adolescent of reproductive effects, loss of fertility. In the leaks, they talk about how kids really can't understand any of this. They should talk about health concerns, like we're talking about cancer risks and things like that. Kids can't understand that. Then there are children recommendations. According to the WPATH, as soon as you start puberty, you're not a child anymore. So they basically, negate saying that they're talking about children by calling all these people adolescents. So that's one of the ways they talk around children. And they basically recommend social transition for children, which data shows if you socially transition children, they're going to continue down the path that things like psychological treatment and therapy, things like socially transitioning, all of that is self reaffirming of the child's new identity. And so it's not far off from just putting people on medications. This is the mental health chapter. Like I say, the biggest thing that we notice is that their biggest focus on mental health issues with transgender people is that you really only need to be able to consent. Otherwise, your mental health issues are kind of irrelevant. And then the other thing I wanted to just mention quickly is like I had said before, how they blame people not doing well after transition on internalized transphobia or on the society around you, not on shitty surgeries, not on lack of good care, not on medications really don't provide a real, like physical change that people are looking for, and not on the fact that they're potentially misdiagnosing people and pushing them down a pathway that they shouldn't be. So this was what I had talked about before, but in SOC 7, the WPATH standards of care, they at least put some age limits on things for when you start cross-sex hormones, when you get mastectomies, breast augmentations, vaginoplasties, or orchectomies. The Dutch protocol said for social transition, you should wait till after people have started puberty. So you shouldn't be socially transitioning little kids. The Endocrine Society is like, we're just a medical society. We don't make recommendations about social stuff. The WPATH is like, nah, we don't care. You socially transition your kids. You need to socially transition your kids. By not making recommendations and talking about how it's acceptable to socially transition, but saying it's really up to like the parents, they obfuscate their complicity in it. For puberty blockers, like I was saying, the Dutch protocol, it was 12 years old. Now, the Endocrine Society has picked up the recommendations from SOC 7 that you can start at Tanner stage 2, which, like I say, is the first sign of any maturity, the first sign of breast starting to form, things like that. But in the WPATH SOC 8, the newest one that came out in 2022, the end of 2022, they say that if you have somebody who's like a late bloomer and age-wise, they're mature enough mentally, but their body, if they're like constitutionally delayed, if they, haven't started to develop yet, even though their mind is there yet, you could start them potentially then. Like I say, they open it up to be, so easy for people to do whatever they want and still say they're within the guidelines. For cross-sex hormones, like we talked about earlier briefly, the Dutch protocol, they started at 16. The Endocrine Society says 16 unless there's a compelling reason to start earlier. But again, they go through and it's medical reasons when you actually look. It's not just, willy-nilly because you feel that way. And then the WPATH SOC 7 says at the age of majority is what it says, meaning once you're an adult in your chosen, wherever you live. And then, in the US, 18. I don't know about other places. And then as far as WPATH SOC 8, they just we don't make any new age recommendations. They didn't cite any new research. They just we don't make age recommendations for these things. It's between you and your doctor. Let's see, in mastectomies, the Dutch protocol, they're 18 for all the surgical stuff, like we talked about. Endocrine Society is just talking about medical care. They're not talking about surgeries. They do mention that vaginoplasties and orchiectomies should happen, after the age of 18, but that's because of I Honestly, I don't remember off the top of my head. I have to reread the stuff and look back. But for mastectomies, the WPATH SOC7 said, you can do that a year after you start hormones. SOC8 is like, whatever. Hormones, no hormones, whatever you want. They've left it so wide open, you can do whatever you want. Because suicide. For breast augmentation, i.e. like male to female people that want to have breast augmentation, because the hormones don't really give you, real breasts. The Dutch protocol, 18, they don't talk about breast augmentation, and no age recommendations for vaginoplasty. And again, like I say, the big point is that they've removed the age recommendations, and it allows people to really get away with a lot. Like I had mentioned, they want to remove definitions. They want it to be in the document. We use the phrase transgender and gender diverse (TGD) to be as broad as possible. Gender identities or expressions that differ from gender socially attributed to sex assigned to them at birth. So one of the things that they talk about a lot in all this stuff, and I have some videos where like gender people and WPATH people are talking about this, is they look at the social, reasons and the social actions of people, apply it to what their perceived societal expectation of gender is, and say, you don't conform to, what society's expectation of a girl or a boy is, therefore you're the opposite gender. The other thing that I have here is that there's in this chapter 2, they talk about avoiding non-standard terminology. They talk about terminology and what you say. And like one of the things is in medicine we use is the terms incidence and prevalence for things. And because they decide that that's inappropriate language and it pathologizes people, then we should use the number and proportion instead. Like we should use different language than we use for any other healthcare issue. We're not stigmatizing people when we talk about the incidence and prevalence of cancer or the incidence and prevalence of obesity. But for some reason with gender stuff, we're pathologizing people when we talk about, or stigmatizing people when we talk about incidence and prevalence in medicine. There's no other thing I've ever come across as a healthcare provider myself where, your language is being policed by the, medical recommendations. Yeah, I mean, I don't know. It bothers me a little bit. This is a doctor named Jeremy Carswell from Boston Children's Hospital talking about as part of the SOC8 Assessment Support Therapeutic Approaches for Non-Binary Individuals work group, how social stereotypes or play with opposite toys is indicative of being of the opposite gender.
A child will often know that they are transgender from the moment that they have any ability to express themselves, and parents will often tell us this. We have parents who tell us that their kids, they knew from the minute they were born practically, and actions like refusing to get a haircut or standing to urinate, trying to stand to urinate, refusing to stand to urinate, trying on siblings' clothing, playing with the quote opposite gender toys, things like that. There is more and more a group of adolescents that we are seeing that really are coming to the realization that they might be trans or gender diverse a little bit later on in their life. So what we're seeing from them is that they always sort of knew something was maybe off and didn't have the understanding to know that they might be trans or have a different gender identity than the one they had been assigned. So that is a growing population that we are seeing, and that's being recognized as being trans and able to be treated.
So what's interesting to me now, having read, since I made these slides and put this together, more of the historic data and stuff, is it's fascinating because the, historically they talk a lot about how much of this is influenced by family dynamics, by the behaviors and, temperaments of the mother and the father and how they treat the children. And potentially, even in some of the earlier case studies, how the siblings of the trans child or adult influence them for similar reasons. And, how play and what you play with and how you play is much more about what is kind of taught to you by those around you, and less so about, your own specific interests per se. Not to say that people don't have their own interests. Like, you talk about a tomboy or whatever, a girl that's more interested in boy stuff, but the reality is whatever allows somebody to express more aggressive and more masculine traits, maybe that, but that doesn't necessarily mean somebody is not male or female.
A child will often know that they are transgender.
This is at a TEDx, and see, I have lost all respect for TED for years now. I remember when TED came out, it was such a big deal, and people loved it, and it was science. But yeah, anyways, this is somebody, a lady named Dr. Angela Cade Gopherford, talking at TEDx Minneapolis in April of 2020. Her talk was The Revolutionary Truth About Kids and Gender Identity. I don't know what their pronouns are, but this individual talking to us is the chief education officer and the past chief of staff for Children's Hospital of Minnesota, and is currently the medical director of Children's Minnesota Gender Health Program, and is a pediatrician in the Children's Minneapolis primary care clinics. Like, these are the people treating kids.
They have figured out their place in the world and they are claiming it. It shouldn't surprise you then that some transgender kids are also claiming their identities as young as 3 and 4 years old. They know the categories, they know how they should feel inside based on their anatomy, and they also know that the way that they see themselves doesn't line up with other people's expectations. From as young as some kids can talk, they're explaining to their parents the truth about their identities. Now, as kids move beyond into the age of 4 and 5, they're starting to figure out gender role, or what does it mean to be a boy or a girl? This is when kids are understanding how they should act based on their gender identities, and they're learning about concepts like boys' toys and girls' toys for the first time, which, even if we don't teach it to them, all it takes is one trip to Target to figure out which toys belong to who. And so they're first figuring out what do they like. They're trying on different ways of dressing, different costumes. They're doing pretend and imaginary play. They're playing with different types of toys. They're figuring out first what they like, and then is it okay or not?
Yeah, I mean, these are all clips from larger talks. I can probably find you the longer talks. These are relevant, but if you're more interested in the topic. But again, like I say, they're
They
very
have
focused
figured out their
on social determinants, not on assessing patients. These are DSM-5 criteria for gender dysphoria. Specifically, the WPATH uses the ICD-11 criteria because it does not like the fact that the DSM-5 and the ICD-10 criteria require extended periods of time of persistence of transgender identity or transsexuality or gender dysphoria, depending on how they write it, to get the diagnosis, whereas the ICD-11 just calls it gender incongruence and says that you don't necessarily need any like extended period of time. The way they write it, and again, it's socially focused. No, I didn't put it here. They say it includes a strong desire to be a different gender than the assigned sex, a strong dislike on the child's part of his or her sex autonomy or anticipated secondary sex characteristics, and or a strong desire for the primary and or anticipated secondary sex characteristics that match the experienced gender and make-believe or fantasy plays, toys, games, or activities and playmates that are typical of the experienced gender rather than the assigned sex. So essentially what they're saying is if they have a strong desire to be the opposite gender based on what they like doing and what they like to play with and how they and what they say, and they're afraid of the secondary sex characteristics of the gender that they were born as, give them the drugs. And this is why the WPATH wants to use ICD-11 and specifically only talks about using the ICD-11 as opposed to using the ICD-10 or DSM-5 criteria that are here. Yeah. Look, I mean, what are GI Joes but Barbie dolls for boys? My sister, that's homosexual, played with Barbies, and she was the kid that was cutting all the hair off them and, like, messing them up. It's just ridiculous silliness. Um, so this is the numbers according to the WPATH. They say that essentially they claim that if you include all gender nonconforming people, up to 5% or so of adults are gender nonconforming. And if you include, and if you're looking at children and adolescents, up to almost 8% on the high end are gender nonconforming. We're talking about like 3% are transgender. What's interesting is if you look at the data from like Canada's census for self-identification, and they allowed, as of 2021, transgender, non-binary. It's for people that are 15 years and older. It's about half of the a third of a percent, 0.33%. And consistent with the like literature that's published, they do report in the data later that when you look at Gen Z, it's like 0.8% of the population identify as transgender and gender non-binary, and in millennials, it's like a 0.5%. This is a kind of creepy video. But this is a girl, whatever, the young boy to girl transgender person who they were doing a piece in, I think, around 2013 on this child, after GLAAD mailed this letter that's on the left to Obama in 2013. And then a Daily Mail article was done. At the time of this video clip, this child is 11 years old. And the WPATH even talks about in their adolescent chapter that adolescents may be driven by alternative motives and rewards for seeking gender care, and not just that they're, transgender. So they used a fake name. I can give people the real name for this person if they want it, but it's kind of irrelevant. Of note, though, this person has now gone on to do, like OnlyFans and porn and all that kind of shit, which something I have noticed is a lot of trans people do sex work.
10 years old,
Online.
Josie Romero believed she was born in the wrong body, and her parents have been seeking a controversial hormone therapy that would start chemically changing her boy body into an adolescent girl's.
14 inches.
14 inches? A foot and 2 inches?
Yeah.
Estrogen treatment is irreversible and would make Josie sterile. But Josie and her mother never doubted it was the right thing until an unexpected conversation happened one afternoon.
But on the inside, where nobody else can see,
Yeah.
are you a boy or are you a girl?
Maybe I'm a boy inside and a girl outside.
Really?
Yeah, is that true?
Only you know the answer to that. So if you wanted to grow up to be a man,
Yeah.
would you tell me?
Yeah.
Hey, if you wanted to grow up and be a man, you could.
I want to be... Sometimes I think I'm a boy, sort of, but I want to be a girl.
Yeah.
Would you let me if I'm a boy?
Of course. I would love you no matter what. I always have, and I always will.
It was the first time Vanessa ever heard Josie sound uncertain.
I feel like maybe there's a part of you that's afraid to tell me what you really want. What if I said, oh, please don't be a girl?
Well, I guess I'll be a boy.
No, honey.
I need to listen to you, my mom.
Well, yeah, you need to listen to me about, what's healthy to eat, and you need to listen to me about what time to go to bed. But you are the one. I have to listen to you.
Yeah, well, if you said I need to be a boy, maybe
No.
I have to.
No. For her to have any indecision now, I don't know what it's rooted in, and I really need to find that out.
I feel like I'm about to cry.
I'm just kind of surprised by some of these answers today. It's the first time you've given them to me. Everything I thought I knew is kind of in question.
Had Vanessa's wholehearted, unwavering support of Josie's transition actually pushed her child too far, too fast?
The thought of her having made such a huge decision in her life, all based on what she thought I wanted, that would be traumatic for me.
Bioethicist Dr. Margaret Moon, who opposes opposite-sex hormone therapy for kids Josie's age, says most 9 and 10-year-olds are not mature enough to participate in life-altering medical decisions.
They're not sure of who they are, and they can't really offer their parent that sort of reassurance.
Even Dr. Olson says there is no exact science that can determine who is truly transgender.
What's missing in the data right now is these exact characteristics mean that this person is for sure going to be a trans adolescent and adult. We don't have that data.
She's correct. There's no data that indicates how a child adheres to gender norms as a child is going to dictate how they are as an adult. Most of the data suggests that gender nonconforming children are likely to be homosexual as an adult. So in a lot of ways, if you really want to get down to it, what all this gender stuff and transition stuff is doing is getting rid of a generation of homosexual kids, potentially. I understand a bunch of you guys are on phones, so I can read this letter real quick. It says, it's titled Sadie's Dream to the World. It says, the world would be a better place if everyone had the right to be themselves, including people who have a creative gender identity and expression. Transgender people are not allowed the freedom to do things everyone else does, like go to the doctor, go to school, get a job, or even make friends. Transgender kids like me are not allowed to go to most schools because the teachers think we are different from everyone else. The schools get afraid of how they will talk with the other kids' parents, and transgender kids are kept secret or told not to come out there anymore. Kids are told not to be friends with the transgender kids, which makes us very lonely and sad. When they grow up, transgender adults have a hard time getting a job because the boss thinks the customers will be scared away. Doctors are afraid of treating transgender patients because they don't know how to take care of them, and some doctors don't really want to help them. Transgender patients like me travel to other states to see a good doctor. It would be a better world if everyone knew that transgender people had the same hopes and dreams as everyone else. We like to make friends and want to go to school. Transgender people want to get good jobs and go to the doctors like they are exactly the same. It really isn't that hard to like transgender people because we are like everyone else. I bet that at least the bullet points of this were written by GLAAD, if not the entire wording of it. I mean, can you write the same paragraph 4 times? Like, really? No, but seriously, I mean, all of what I read in there when I look at that is somebody, if this is all real and this is the kid's actual beliefs, that somebody is abusing the hell out of this kid and, like, you know, telling them that they can't do things and be things, whatnot. Yeah, the whole thing disturbs me. Sorry, I know I've said that like 4 times. Again, newer data along with the historic data shows that many mothers of boys with gender identity disorders have sorry, Brett, you crack me up. But yeah, 53% of the study's findings were that 53% of mothers with boys that have gender identity disorder had borderline personality disorder compared to 6% of the control group. You know, the old data, the new data, the current data, it all seems to suggest that the mothers have a lot, or it's something to do with, well, I should say mothers and fathers have something to do with kids being trans. The, you know, home life and what you're exposed to at a young age is very important. This guy, Gordon Guyette, I'm not exactly sure if that's how you pronounce it, but he's the one who came up with the term evidence-based medicine in the 90s, which is what like medicine's kind of big deal is now on how you make decisions, evidence-based. Even he wrote an article for the British Medical published in the British Medical Journal, talking about how gender care in the U.S. is untrustworthy, that policymakers, physicians, families should all take heed, because the work that's being published by people like the WPATH is not evidence-based. This is where I was talking about. So, with the mental health section. So, they say it's important to recognize mental health, in particular symptoms of cognitive impairment or psychosis, that can impact a person's ability to grant consent for gender, medical, and surgical transition. Sorry, I can't remember the top of my head but for medical and transition and surgical care. This is also from that chapter, and they say that the presence of psychiatric illness or mental health symptoms do not pose a barrier to obtaining gender affirming medical. Oh yeah, that's it. Gender affirming medical and surgical treatment, unless the psychiatric illness or mental health symptoms affect the transgender or gender nonconforming person's capacity to consent to their specific treatment being requested, or affect their ability to receive the treatment. Which legitimately means that you can take a patient, and this guy here on the right is being hyperbolic. If somebody's actively psychotic, you can't. But even in the leaks, there's things talking about how, I had a patient who was psychotic and now they're not. Can I consent them? Um, you know, can I consent them if they might have a mental breakdown the line? The reality for the way WPATH is written is, as long as you can, feign consent, you can proceed, and you don't need to treat mental health issues. And then, like I was saying, all of their stuff is claiming that, it's about suicide prevention. But despite that, it even recognizes the high rates of suicide, and they don't go down. They recognize the high rates of autism. So I'll read for you what I circled in red here. This is from their page on mental health. They say high rates of suicidal ideation, suicide attempts, and self-harm have also been reported. In addition, eating disorders occur more frequently than expected in non-referred populations. They're saying they're trying to make the argument you should get treatment. So they're saying that in people that are not referred for treatment, the eating is worse than in people that are referred for treatment, but it exists in both, the eating disorders. And then they say, importantly, transgender and gender nonconforming adolescents show high rates of autism spectrum disorder characteristics. Other neurodevelopmental presentations and or mental health challenges may be present, such as ADHD, intellectual disability, and psychotic disorders. And then they also talk about, and this we see in the leaks and some of their other stuff, is that they say the discussion should employ developmentally appropriate language and teaching styles, and be geared specifically to the needs of individual patients. And so there's stuff talking about how, like, if you have a severely autistic child and they can't understand, how do you still consent them? Can you still consent them? And they say, the SOC8 discusses that you should make sure that even if someone's neurodivergent, that you discuss with them body parts and functions, changes, and all this kind of stuff. But it's very wishy-washy on how you actually consent these people. So this is the lead author from the mental health section of SOC8 at the National Trans Summit in May 2023, talking about severely autistic and nonverbal patients and their communication, and how you could, get consent from them by having them draw gender.
This particular patient I'm thinking of, despite their quite severe autism, is very clearly trans and clearly, benefiting from being on estradiol, and if anything is, just impatient for more feminization, and wishes they had gotten treated earlier for that reason. Yes.
Oh, I was just thinking to add to that. I think it's really important when we submit an assessment to basically say the problem is with the assessment requirements and that they're very neurotypically designed.
That is correct.
And that just preface it by, due to that, I
The problem is the assessment tools that we're supposed to use are not designed for neurodivergent people. They're designed for neurotypical people.
used other measures in information.
So not like, hey, let's come up with a systematic way or understanding, or maybe we need to go back to the drawing board and reassess. No, let's just have them draw their gender.
Particular person and essentially educate people around there's different ways of knowing, and if we use the standard template, we're not going to find out. We may have to depend on parents, we may have to depend on drawings, but we can't just say, well, until you can be verbal and answer the questions as we have in this assessment packet, we can't clear you. That's
For
really
those that
discriminatory.
can't hear that information, if considered an education opportunity, maybe for those above us that don't understand ASD as well as, some clinicians do. Because even though there was obvious communication in some of the assessments that I did, I still got pushback because there was not enough coming from the person themselves and instead from the parent. So it's very, very frustrating because you're correct. It's very, very neurotypical and it drives me crazy. And I'm hoping that in the future we can change that.
Well, it's interesting you mentioned drawing, because this particular patient is able to draw her feelings better than to speak them. And so sometimes that can be, and enjoys drawing much more than enjoys speaking, basically.
Yeah.
And so, so I think that's a good point to bring up, that they're
Adolescent, Brent. So, somewhere between the age of, let's say, like 8 and 14 would be my guess. So this is the extended cut of more pieces from that House committee hearing where we saw earlier with Dan Crenshaw. I cut this down to 3 clips. It's about an hour long. If anybody wants to watch the whole thing, I can give you a link on somebody else's channel that cut it all up well. They gave me permission to use his cut to get stuff. So I mean, obviously it's public video, but so the first 2 clips, they're talking about suicidality, and then the third clip I'll point out next. But again, this is the argument that the WPATH uses for everything is suicidality. The woman in the middle is that lady, Meredith McNamara, that was talking before, who's from Yale. This lady on the right, she's an anti-trans person, and if you watch her face, she's just so angry the whole time. Her name is Miriam. Yeah, I know she's a Jew. Miriam Grossman or something, or Wasserman, or forget what her name is, but she's a pretty public figure. She's done a lot of testifying at the government stuff.
It is toxic for an adult to tell an adolescent that there's something wrong with them. I'm sure there are many parents in the room and you'd never want your kid to go through that. Suicidality is a debilitating way to endure adolescence. A suicide attempt is a traumatic interruption in a young person's life. Let's be clear. Pediatricians know that life-saving means life-sustaining. When trans youth receive the standard of care, they thrive. They develop talents, they discover their strength. I think that one of the reasons why rates of suicidal ideation over the past couple of years and other mental health harms in trans youth has been going up is because of how they've been demonized.
Providers must consult with parents.
So again, those first 2 clips, first it's suicidality is the reason we should do this. Suicidality is going up because people are demonizing, trans kids. That's the reason why people are committing suicide. Sorry about the shitty cuts. I've never had edited before when I cut this up. I could do better.
Parents and legal guardians about kids.
So the point of this clip is that what essentially it boils down to is they're arguing that parents know their kids better than doctors, and so we should be taking the parents and the kids' words for everything.
That's provided to children. Could you explain to this committee and to my colleagues the importance of informed consent when providing all kinds of medical care to our youth?
Absolutely. Thank you for your question, Congresswoman, and thank you for your comments. It makes my patients feel safer. Parents play a central role in all medical decision-making for minors in the vast majority of cases, and regarding medical treatments for gender dysphoria, it's no exception. Parents know their kids best. They know what they need. We as pediatricians rely on their knowledge of their young person in order to help support them best. In the case of medical treatments for gender dysphoria, the standard of care and the way that care is practiced in this country is with a multidisciplinary team with an iterative over several visits, several months mental health assessment, and long conversations.
Yeah, that's all bullshit. She's quoting, WPATH at the end there, but there's nothing in the WPATH's care recommendations that say you have to take months and multiple assessments or any of that. They talk about it in part of their wording and it being iterative and whatnot, but they don't say that in their actual recommendation of what you should do. And as Crown Target points out, yeah, I mean, there's no like empirical data for these things they're doing, and they're just kind of doing what they think might be right without any real long-term follow-up. What the data on follow-up shows is that people are generally happier, in the first few years, and then at somewhere around 7 years after, the dysphoria sets in, and so it's not back in. So it's not a gender dysphoria to gender youth, to happiness for most people. It's gender dysphoria to gender euphoria back to gender dysphoria. The suicide rates after transition, again, fluctuate, but I believe the suicide attempt rates are both pre and post transition somewhere in like the 60%, or it could be 40%. A lot of numbers bouncing around in my head. I'd have to look it up and give you a 100% answer, but I know the reason I'm mixing up is because I think it's 40% higher than the standard population of the age group, and so it's like 60%, and the standard population for that age group is 20 or 21%. But at a later date, we can talk about how there's a bunch of new Finnish data that's come out on suicide rates showing that the whole claim about transgenderedness leading to suicide kind of being BS.
It is toxic for an adult to tell
Yeah, I mean, exactly. The doctors are supposed to listen to the parents, and the parents are listening to the children, and the doctor's supposed to listen to the children. And it's just a never-ending cycle of, needing to affirm whatever you're being told. So these are some issues with the SOC. It does not reflect in any way that often gender incongruence or sex and stuff like that is a sign of trauma or some other issue. What do I have? Okay, so I do have some numbers here. Okay. So suicidal ideation, the rates that it has here in the current presenting to trans clinics is 41%. And the actual self-harm rates are 16%, and the actual suicide attempts is 10%. So there you go. There's some numbers for you, cowboy. Medically, there's a boost in euphoria by sheer side effect of short-term. Yeah, for female to male, 100%. But it's also, I think it's this sort of general psychological thing about, you're seeking something. Like, even for me, I noticed when I was in school, because I was focused on achieving something and getting to an end goal, I continually was focused in the moment. And then once I finished school, because I wasn't so focused on individual things and being in the moment per se, I was very lost for a little while. So, I mean, in a lot of ways, it's very typical, I think, of human nature and not just of the hormones themselves. Because you see, I think, if I remember correctly in the data, similar stuff for that between both female to male and male to female trans people. And like I say, the current presenting is actually slightly higher female to male ratio. Yeah, it's like a honeymoon phase, exactly. And people are showing high levels of distress. Like I was saying, suicidal ideation in the current presenting groups is about 40%, with self-harm rates at 15% and suicide attempts at about 10%. And as far as comorbid health condition, mental health, like I was saying, 63% have anxiety, 62% have depression. Those may be the same group of people. 35% in this data have behavioral disorders, and about 15 to 20% have autism, depending on what data set you look at. And most have families with mental health issues, issues with family conflict, abuse is something like 40%. And then one of the things that I put up on screen here that I showed is just that, the people with gender dysphoria that self-report, many of them don't have a lot of friends. 50% have more than one close friend, but like as a whole, if you add up the rest of 50% of people have very few friends, if no friends. So I think isolation plays into it a lot. And then, they talk about how accepting people are. And like I say, as a whole, it seems parents, especially mothers, are pretty accepting of their kids. Yeah. I mean, look, the original sexologists and doctors and whatnot believed very strongly in the idea that sex was binary, that hormones were binary, and that you were transitioning from one sex to another, and there was an endpoint. But now they want to get rid of the entire concept of gender because they bought into all this like insanity. This is a lady named Erin Baroni. She's a pediatrician that treats kids at UCLA, specifically trans kids. And she calls herself Queer MD on TikTok. All these people are on freaking TikTok, all these trans treating doctors and whatnot. And just to note, UCLA uses the WPATH SOC8.
With the bone density concerns and fertility issues, again, we don't see these as things that are contraindications to treatment or something that really impedes treatment. We, just like we do with all, I think, medical things, is try to outline what we might be monitoring, risks, benefits, reversible things, and really have a thoughtful conversation about things. From a true medical and study standpoint, I think Dr. Conran alluded to this a little bit. We haven't really seen the bone density data pan out to be a concern at all in really our trans masculine patients, or non-binary masculine patients, and our trans feminine patients. Potentially there's ongoing studies with pediatric patients. But like I was kind of alluding to before, we somewhat expect that when somebody is going to have more, their body's going to be more similar potentially to folks that we associate certain health risks for, we kind of are just putting people in different categories. So I don't know if that completely makes sense, but that's the way we frame the context of the conversation. And again, suicidality is a real thing, malfunction in school is a real thing. We're really always taking into account what is happening for the individual in the room and how some of these interventions and affirming things we can do are going to help that person function.
So she talks about overall function. She talks about, she blows over the health risks associated with puberty blockers. That's what she's talking about here. We do know that it affects bone density, it puts you at risk for cancers, it affects brain development, it affects heart and other internal organ development and size and things like that. It affects how your growth plates close and your ultimate overall size. You can gain a lot of weight with some of the hormone stuff. But she's basically saying, as per the WPATH, the risk of suicidality, the risk of people harming themselves is so great that those are not really huge concerns. This is a clip from, I think this got me shut down last time we played this, so I'm just gonna skip it. But it's let's see. Yeah. There's a couple of documentaries that I found talking about some of these same things I've been talking about that I'm happy to link to people in a Discord if we share Discords. I mean, like I say, I'll post this stuff in the Unstable Kids Arby's Tranny Clinic. I have to drum up the links again. I have to remember to do that. But there's a new one that was put out by some French Canadians that also got dropped a few days ago. That's good. But here, I can find a link for this real quick, and I can put this in the. It's a like 6-hour series or something. But here, I'll post it in here. That's the link to the first one in this series. People can check it out and watch it if they want. It's an interesting documentary series. It's like, I think 4 episodes or 5 episodes, and they're about a half hour to an hour long each. But yeah, I got struck last time I showed it, so I'm just going to skip it.
Mental health.
This is from a 2020 Pennsylvania House hearing on gender and sexuality. This is from the Children's Hospital of Philadelphia. Oh, sorry. Okay, so the person that's testifying is the Children's Hospital of Philadelphia Gender and Sexuality Clinic co-founder. And this is them explaining that there's no lower age limit for top surgery for trans kids.
Surgery, as it's called. What age does that generally happen? And also, what about bottom surgery? What ages are we looking at?
And then in terms of surgeries, as I mentioned, top surgery is the only surgery at this point that the major medical professional organizations are recommending that there be no lower age limit for that surgery. And so in general, though,
and I included this because when she's talking about major medical organizations, like I showed you, she's talking about the WPATH. She's talking about all these groups that base their decisions off the WPATH.
Most youth who are having top surgery are over the age of 16. And I provided 2 references in my testimony to published studies which were about the benefits of top surgery.
We've seen kids as young as 14 or maybe younger, if I remember correctly, that have had top surgery. This is her saying, okay, right here. She's referred children as young as 14 for top surgery, even though she just said that we're not doing it for people under 16. And when pushed, she goes, age is a number where a child is cognitively and socially is more important than the exact number of their age. Like I said, that's WPATH shit right there.
That you would have referred a patient for either of those surgeries.
So for top surgery, we have referred, and again, we don't recommend the surgery. This is based on over time working with a young person and their family and what decision seems right and developmentally appropriate for them, that they would be sometimes receiving a letter of support or a referral to surgeon as young as age 14 is probably sometime between 14 and 15 is the youngest. But again, like I said, the majority are happening closer to 18, more between 16 to 18. And again, I think it's really important to remember that age is a number, but as an adolescent medicine and developmental specialist, we know that where a child is cognitively and socially is more important than that exact number of their age.
So yeah, I mean, like I say, they are more interested in where people are at than caring about age. So this is an email between the same lady and Rachel Levine, our beautiful and accomplished and brave and whatever else Secretary of Health and Human Services. But this is from when she was the Physician General for Pennsylvania for their health department. And she is looking for literature to support gender confirmation surgery protocols in minors. So she emails and says, good morning. I know we have discussed the USPATH, which is the WPATH, the US branch of WPATH. Or sorry, she's referring to the conference. I know that we had discussed at USPATH the possibility of gender confirmation surgery for young people under 18 years of age. This could include top surgery for trans young men, so female to male, and top and bottom surgery for trans young women, so male to female. Is there any literature to support this protocol? Please let me know if you have any references. So they know what they want to do, and they're just searching for some literature to back it up. And so then this Nadia lady we were just watching replies. This is from back in 2017. Hi, I'm not aware of existing literature, but it is certainly happening. I think we've had more than 10 patients who have had chest surgeries under 18 as young as 15 and one bottom surgery at 17. I'm going to send you a separate email with a picture I took of some poster that talks about chest surgeries under 18. Yeah, I mean, that's why I say, like, as far back as 2017, they were already doing this and talking about it and, you know, very happy to do it on young children. I included this. So here's where I was saying that kids as young as 12 had surgery. So this is a study looking at happiness of people with surgery. 81 patients were enrolled. The average age was 18, and 36 of the participants in the surveys were between the ages of 12 and 24 when they had top surgery. So that's why I say top surgery happens as young as 12, even if it's rare. And the other thing, like I was saying here before when I was talking about complications, here I have the actual numbers written down on my notes on this slide. But for phalloplasties, although most patients report physical and psychological satisfaction, the complication rates are as high as 25% for the flaps where they take from the skin, and up to 64% for the actual penis portion itself. So, yeah, lots of complications. I don't think this is one that got us struck last time. This is a good one. This is Deborah So, who I forget what her actual she does, but I know she writes and stuff. She's a doctor. I don't know what she does now. And then Marcy Bowers, who is the head of the WPATH and a trans woman herself, and is a surgeon that does trans surgeries. And of note, she is the person that did Jazz Jennings surgeries. Jazz Jennings has had a number of revisions, from what I understand, because of complications.
The following program contains mature subject matter. Viewer discretion is advised. As we further examine gender identity and debate whether kids are transitioning too soon, Once again, we're joined by a gender reassignment surgeon, Dr. Marcy Bowers, and neuroscientist, Dr. Deborah So. Dr. Bowers, don't you have concerns about the reports that kids as young as 12 are crowdfunding?
Like I said, people are crowdfunding, paying for surgery.
For cross-sex hormones.
Starting hormones at age.
Oh yeah, and Brent knows what I'm talking about, but there was also the homemade stuff on the Catboy Ranch.
12, no, I don't think anyone's in favor of that. Puberty blockers at age 12, however, where you're given a chance to get that time that you need to see if it is a real phenomenon, yes, that makes a lot of sense.
Oh, damn it. And they push these things as benign, like, oh, it's no big deal. It's giving you time to make some decisions about who you want to be and how you want to be. And, there's nothing wrong with it.
Get that time that you need to see if it is a real phenomenon. Yes, that makes a lot of sense.
As a physician, I just feel uncomfortable. Why would you block a natural physiologic part of your body development? Let it play out.
And like I said before, the data shows if you let kids just grow up and go through puberty, that solves the problem without the mental health issues.
Purposely stopping puberty, to me, just doesn't make sense physiologically.
Yeah, that's a good point, Dr. O. And I think the answer lies at the intersection between what's the emotional and psychological harm that's being done to your child who's having this gender dysphoria and is really struggling figuring it out versus what are we doing from a biology standpoint with these hormones being interjected into their bodies at that pivotal age where they're about to get the surge. Dr. So, let's bring you back into this. What is your take on transitioning with hormones at a young age?
As a former scientist, I operate based on the data. We do not have long-term data for this intervention.
And the long-term data that we do have shows that this stuff is not good.
In this population, we do have data.
Because the first time we put kids on these meds was early 2000s.
To suggest that there are some differences associated with puberty blockers, including less bone density. In one study, it showed that there was reduced spatial memory. And this does not alleviate symptoms of gender dysphoria. It does not improve psychological functioning in these children. For me, I would have less of an issue if this climate were less political and children, upon reaching puberty, if they could get an appropriate assessment and proper therapy, a clinician decides that that's the right choice for that child, I would have less of an issue with that. But we're in such a highly politicized climate right now. The clinicians who are skeptical of this are abandoning the field. They're not working with these patients because they don't feel they can do their jobs properly. I speak to some.
I love the moralizing in the bottom right corner. And, her response, because she's still the president of WPATH, to the leaks, in my opinion, was more moralizing about being a bunch of experts and knowing better.
Many of them all the time, Dr. Marcy.
Can I just answer a little bit of that, though, please? Puberty blockers have been used safely since the 1970s. This is not a new thing. There is a condition.
So this is an obfuscation that they make, and she's about to say, but there's a condition called precocious puberty. Yeah, it's been used since the 70s, but that's short-term use, maybe 2 years max, and it's not changing people's, genders. It's not blocking hormones for long periods of time like the WPATH's recommendations would allow one to do. It's merely delaying a normal process that has already started.
Where someone goes
with
through
children with gender dysphoria, though,
and it can be. Hold on. Yes, it's also used in gender dysphoria, and that also is safe as well. Interestingly, the bone density issue that you mentioned, that is the only significant side effect of puberty.
Do you acknowledge that desistance exists? So desistance is when a child no longer feels gender dysphoric.
We all know that desistance exists, but this is again the role of mental health therapy. If you can narrow the subset of individuals to those.
The WPATH doesn't recommend mental health therapy just because you're expressing gender dysphoria or whatever.
Those who truly feel that they are of the other gender, which is exactly how therapy proceeds, the persisters then have a reasonably high, extremely high chance that there will never be regret or detransition.
But yeah, we were talking about the finances a little bit before, and just playing a clip from Vanderbilt where they were talking about, oh, a gender surgery, nets the surgeon 20 grand. So, you're talking about even more for the hospital. I mean, a week-long stay, all the care, easily that's $100,000. And, like you're alluding to here, I was also discussing how, you're talking about revisions. I think 60% of the patients require revision surgeries. And you can see all these people posting pictures all over the internet of their messed up genitals and their multiple revisions and things like that. This is another clip from that documentary that I posted the link to. I think this is from part 1. Again, I can't play it because I got struck last time, so I assume I got struck again, and I don't feel like sitting here for like 4 or 5 minutes, pausing every 30 seconds. So I highly recommend it. Please go watch it if you're interested in the topic, and don't mind watching
Me towards transitioning.
Subtitles. So, like I say, there are risks to puberty blockers, even for transitioners. And she's the president of the WPATH is talking about how, on the left, how or on the video that we just watched about how it's safe or whatever. But even they recognize that there are problems. They say treating a transgender, gender non-conforming adolescent with functioning testes in the early stages of puberty with a puberty blocker, a GnRH antagonist or agonist, not only pauses maturation of the germ cells, but also maintains the penis in its prepubal size. This will likely impact surgical considerations if the person eventually undergoes a penile inversion vaginoplasty, as there will be less penile tissue to work with. In these cases, there's an increased likelihood a vaginoplasty will require a more complex surgical procedure, such as intestinal vaginoplasty, where they take a portion of the intestines and use that to create the vaginal canal, the neovagina. I think I know of 2 cases where somebody has died from sepsis after that procedure. But the point is, even for them who they ignore the actual, well-known side effects of these medications that are becoming, that were well-known before and are becoming quite obvious now, they even have their own issues for what they want people to do when recommending this kind of care. And then here's Rachel Levine, talking about how, she had transitioned when she was young. She wouldn't have her children, and her children are an important part of her life. And meanwhile, in the leaks, we see them talking about how kids can't really understand that they're giving up their ability to have children.
And then, my transition was very different because for many reasons, professional and mostly personal reasons, I transitioned over 10 years. Okay? Most people don't take that long to transition. First of all, young people are not willing to do that anymore. And, I don't know if I was 15 now, I don't know if I would have taken so long, but again, when I was 15, what were you going to say and who would you tell and how would you possibly express that? But so the language started about, and that was now 20 years ago when I kind of started this journey. And it was starting to become more in culture and the internet and support groups, etc. So, so I took a long time. I don't regret any of that, but I have no regrets because if I transitioned when I was young, and I wouldn't have my children. I can't imagine a life without my children. And so every experience led me to here, and so how could I regret that?
And to me, it's just, I don't even think these people realize how hypocritical they are being or how warped it is that they, on one hand, are pushing kids down these pathways that, kids don't understand. In some of the leaks, they talk about how, kids say, oh, well, I'll adopt, but they don't understand what that actually means. They just think you go to an orphanage and they hand you a baby. Or people think, that they don't understand how IVF works or freezing, and how can you freeze sperm or eggs if you're not old enough to produce them, properly yet? It's just so messed up. But it's so hypocritical how people don't see, even people within this community, how, they're pushing kids for harm reduction down a life path that is leading to harm. I mean, we know from, eons of human history that the pathway to happiness is forming human relationships, spousal relationships, families, children, communities. And by pushing people down these paths, turning them into eunuchs or essentially eunuchs, you're cutting them off from that. You're turning them into a paycheck for a medical system and a population that you can essentially control on some level.
And then,
So this is a clip from one of the actual leaks that came out, which is a long form video with a bunch of clips from this. Project Veritas got a hold of a short piece of this last year. That's what this is. But we can go through the full piece at a later date. Because I think what we'll do is we're getting to the end of this. Now that we've laid the groundwork, I think next time we get on, we'll go through the leak stuff now that we've gone through what the groundwork is. And then after that, we'll start, I think, going into, more of this historical stuff if people are interested. I want to talk a whole bunch about the lies that are pushed by the WPATH specifically and like their cronies, claiming that things like two-spirit and third genders historically and from other cultures are the equivalent of modern transgenderism. And then, like I was saying, I want to go into some of the original data that was out because it seems to me to be much more in line with what is real. And then I haven't gotten to doing my reading that I plan on doing on it, but I do want to read some more on autogynephilia and rapid onset gender dysphoria, the papers, and then at some point talk about that stuff with you guys. But this guy's Daniel Metzger is his name. He is a doctor, and he's a WPATH certified pediatric endocrinologist who is well connected in the WPATH and has been part of writing stuff. The guy in the upper left here is a psychotherapist that's a transgendered person who wrote one of the sections or helped write one of the sections. This guy, I can't remember what he does, but he wrote one of the sections for WPATH. So before I hit play, one of the things that's interesting about WPATH is unlike other medical organizations that spend money on research and education, they spend their money on education and lobbying. So this is one of the things they do is this gender education institute stuff. So this was him talking.
Some of the Dutch researchers gave some data about young adults who had transitioned and reproductive regret. And it's there. And I don't think any of that surprises us. I talk about it, but most of the kids are nowhere in any kind of a brain space to really, really, really talk about it in a serious way. That's always bothered me, but we still want the kids to be happier in the moment, right?
On Monday, October 3rd, the American Academy of Pediatrics, the American Medical Association, and the Children's Hospital Association delivered this letter to Attorney General Merrick Garland. Now, this comes on the heels of Project Veritas receiving inside tape from within the World Professional Association for Transgender Health, feigning regret regarding their 14-year-old patients.
It's always a good theory that you talk about fertility preservation with a 14-year-old, but I know I'm talking to a blank wall. And the same would happen for a cisgender kid, right? They'd be like, ew, kids, babies, gross. Or the usual stock answer is, I'm going to adopt. I'm just going to adopt. And then you ask them, well, what does that involve? Like, how much does it cost? Oh, I thought you just went to the orphanage and they gave you a baby. No, it's not quite like that. I think now that I follow a lot of kids into their mid-20s, I'm always like, oh, the dog isn't doing it for you, right? Yeah, they're like, no, I just found this, wonderful partner and now we're kids and da-da-da. So I think, it doesn't surprise me, but I don't know still.
So, excuse me. The da-da-da that he's leaving out there is people saying, yeah, I mean, I'd like to have kids. I can't, the dog's not doing it for me. But I don't know what I can do, but, kind of is what it is. I'm just going to live this way. And then they don't record that as, somebody outright saying, I have real regrets. They record that as somebody being like, happy with the outcome. Because they'll say, I'm happy with my genitals. I'm happy with my gender. But, they're not going to sit there and be like, yeah, my life really fucking sucks because I want to have a family and I can't, and I want this and I can't, and then, this doesn't work. And, I have problems. I have to sit, I have to stand when I pee because if I sit, it goes everywhere, even though I'm a woman. Like, you know, there are all kinds of problems, but these people ignore it when they report happiness in these surveys, you know, or into their, you know, data for how they present it.
What to do for the 14-year-olds. The parents have it on their minds, but the 14-year-old, it's like talking with diabetic complications with a 14-year-old. They don't care. They're not going to die. They're going to live forever, right? So I think when we're doing informed consent, I know that that's still a big lacuna of that we do it.
Now, contrary to Dr. Metzger's own statements, the letter sent to the Department of Justice would consider any criticism or public review of these procedures as disinformation. Providers of evidence-based gender-affirming healthcare and their colleagues are facing increased stress and fear, rooted in an intentional campaign of disinformation, where a few high-profile users on social media share false and misleading information, resulting in a rapid escalation of threats, harassment, and disruption.
Some of the Dutch researchers started
this is from she's talking to the Mount Sinai Health System, and this is from 2021. This is Marcy Bowers right here, the president of the WPATH, and she's discussing how in their recommendations in Chapter 12, they say that we recommend healthcare professionals begin pubertal hormonal suppression in eligible transgender and gender diverse adolescents after their first exhibit physical changes of puberty, so Tanner stage 2. And like I was saying, in Tanner stage 2, we're stopping people right as they first start showing signs of puberty. And it's going to cost them, you know, certain biological functions, especially, you know, sexual function in the future. So listen to what she has to say.
The second is was an observation that I had, that every single child who was, or adolescent who was truly blocked at Tanner stage 2 has never experienced orgasm. I mean, it's really about zero. These are of course, these are just assigned male at birth, so trans feminine, and it's because they never in their lives are exposed to testosterone. That doesn't change. So blockers prevent the rise of testosterone, and they don't really go on testosterone at or around surgery or into adulthood. And so we don't know. They're going to have this sensation. There's no question about that. But are they going to be able to achieve sexual satisfaction? It's important in relationships. And I know that from my work with female genital mutilation survivors, that the lack of being able to be intimate with a partner is very important. And so this is what really raised the red flag for me, is to say, look, we need to have our eyes open about it. I think it's been beneficial talking about it. I know Joe and many others have reported to me, you know, they've changed their approach a little bit in their informed consent models, and that we're talking about masturbation now. We're talking about, okay, that's an area of the body that's got very dysphoric for you, but you know what? It's all a penis is just a large clitoris. I mean, it's all the same material. It really is. So you know, use it for the pleasurable purposes, partially that it was intended, and you know, we'll see what happens. But these are to be answered questions. So can we avoid puberty and get good adult results? And secondly, how do we assure someone that they're going to be able to be sexually responsive? Do we remove the blockers during the course of their adolescence and let a little bit of puberty come back? Do we delay it a little bit, maybe into Tanner's 3 or 4, maybe before they have their first orgasms, maybe?
You know, and she's told people before that she's concerned about how people are politicizing their concerns about this kind of stuff. And she told Barry Weiss's Free Press in October of 2021, a year before they published the WPATH 2022 update, that she's not a fan of Tanner 2 blockade because, you it affects surgical outcomes. And yet in the actual recommendations, it's go ahead, Tanner stage 2 block.
The second.
So this is from that Pennsylvania hearing. Talking about fertility.
I want to make sure I understand the full range here. So puberty blocking drugs, followed by the cross-sex hormones. It's my understanding they can prevent the full development of the penis and the breast, and can even result in loss of fertility.
The questions about fertility, these are important ones that we discuss with patients and families early on and often. So we certainly have discussions prior to starting puberty blockers and prior to starting gender-affirming hormones, testosterone or estrogen. What's interesting is that the field of assisted reproductive technology is rapidly evolving, and our understanding of the impacts of these medications on biological fertility are also evolving. I also want to take a step back for a second to say that, transgender youth and their families, just like everyone else, may, are aware of the fact that there are other ways to build families beyond having a child biologically, right? That folks can adopt as well. And many transgender children and adolescents are interested in having biological children, and many are not interested in having children at all, or are interested in adopting.
We just tell ourselves whatever we want to help ourselves sleep at night. The WPATH basically blows off detransitioners. One of the interesting thing about detransitioning in the WPATH is that the WPATH suggests that you need 2 mental health assessments for detransitioners, but for transitioning, you don't need a mental health assessment at all. Because their reasoning is that, when people see multiple mental health specialists, they tend not to go down the detransition route, and once and transitioning is a good thing, essentially, paraphrasing. And this was an article in Reuters talking about how, the science is kind of questionable. This is from 2022, December 2022. And anyways, I just wanted to read this one piece here where they quote Bowers and say, however, Bowers, WPATH president, is among several gender care specialists who say patients are ultimately responsible for the choices they make about treatment, even as minors. They should not be blaming the clinician or the people who help guide them, she said. They need to own the final step. And so one of the things about this is WPATH and all these people involved in it feels that they're not responsible for the decisions their patients make, because they're just affirming the patients. And the WPATH, again, it acts as a legal, protection essentially for them, because they can sit there and say, well, we're following a guideline. I think whoever follows WPATH needs to, run from it and protect themselves. I think if I were a legal person, I'd be worried, but I don't know. But yeah, it's disturbing, to say the least. This is another clip from that transition thing, the documentary I posted. So, please, like I say, it was pretty good. Check it out. And then this is the data, one of the articles, but this is some data that shows that it basically, if you start patients on blockers and you go down the hormone pathway and you socially transition, people will persist with their gender identity and they'll stay transgender. But if you do not do any of that stuff, they will desist and they will remain the same gender, choose to remain the same gender. So historical studies, I just use this as an example, but historical studies show somewhere between 60 and 98% desist. But if you take a good weighted average based on the quality of the evidence from them, going back to the 70s, these studies, you're talking about 67 or 68% of people that express gender, nonconformity persist in their transgenderness if you do not intervene at all. So that means that, like I say, 30% will persist and 70% basically will desist. So if we're pushing 70% of people that would normally desist down a persistent pathway, we're creating a lot of risk for people, from a mental health standpoint. And that's why my personal argument is, if we know that treating people with puberty blockers is going to push them down that pathway, we can't even claim that they're benign intervention in any way whatsoever. What is this from? Okay, this is from the documentary I can't show again. This is the sister. Why did I say sister? Detransitioner. But hang on, I lost my slide because of that. You're not supposed to see that. Look at me, I'm terrible at this. But yeah, so they're stopping using puberty blockers. This is from website Transgender Health Map that shows you where you can get stuff and not. But they're cutting it back. In February 2022, Sweden's National Health Board, officially stopped doing stuff outside of clinical trials. They're trying to do actual clinical trials. Like I was saying before, the Tavistock clinic got caught up in a whole bunch of problems because they were burying the fact that they were pushing autistic kids down the trans pathway, and got shut down, I believe, as of March of 2022, based on independent report that the National Health Service requested. And what they said was that it's not safe or viable as a long-term option for the care of young people with gender-related distress due to the hiding of these like autistic kids. In their internal review, they said 35% of patients showed autistic traits. And the NHS's new solution is to focus on only treating for underlying psychological stuff and only doing puberty blockers in clinical trials with an informed consent model in the NHS. But unfortunately, people are still accessing it privately in the UK. They just opened a private gender clinic. This is a news piece about it. But we're gonna skip it.
The GenSpectre Group is an international.
But yeah, so I think for now it's a good like I say, kind of baseline, and then I think next time we stream we can go through these actual things and talk about the leaks and the emails and whatnot. Now that everybody should have a kind of baseline, and if people think of questions or thoughts or things that they think be worth discussing, take a look at it, and we can discuss next time. I mean, I don't know about consistently, let's say like stream it on Wednesday nights every week, but I will make sure to put out notice next time that I'll stream probably in the next couple of weeks, because maybe even next week. But I'm going to start going through some of this stuff to find some interesting stuff to talk about. But I will happily discuss whatever if they're interested on the topic. I don't know if anybody has any questions at the moment that they want or to ask or whatnot. If not, then I'm going to call it a night. Guys, have a good one. It was nice to do this again. I hope it was interesting and comprehensible. Y'all have a good night, and feel free to send me any messages in Discord if you have questions or want me to look at anything.